Almost exactly 50 years ago, I became addicted to a new program on PBS. It was called Nova. Has anybody ever heard of it? And the fourth program that first year was, the first season was called Strange Sleep. And it was about the discovery of anesthesia and at times the tragic consequences for its discoverers. And I have absolutely no doubt that Dr. Wallace is familiar with it because I just mentioned it to him 5 minutes ago. He hadn't heard about it before. Anyway, ever since then, I've been fascinated by the amazing magic that is anesthesia. Whether it was my parents or a friend like Carter Roberts, whenever they'd undergo surgery, I would always ask the anesthesiologist what medications they would be using. And they would always stare at me strangely and ask me why I would want to know that. And I'd usually respond with something like, oh, I'm just an anesthesia junkie, which was probably not the best response I could have given. But usually I was able to pry the information out of them. And since then, I've become familiar with some amazing drugs such as morphine sulfate, Versed, propofol, which is the drug that tragically killed Michael Jackson. And that interest has now become more than an academic interest of mine because in 3 weeks, I will undergo hip surgery replacement, something that would be absolutely impossible without the discoveries of people like Dr. Wallace. Thank you very much, Dr. Wallace, and you and your progenitors. I will bet that there's not a person in this audience who either has not had major surgery or someday will not have major surgery. We are all indebted to people like him. Okay, now that's my little thing. Now I'm going to go to, let's see if I can find the rest of this. Don't laugh at me, Rebecca.
I thought we were supposed to laugh.
Oh, well, maybe. Okay. So anyway, tonight, this is your part now. Dr. Art Wallace, who is an MD and a PhD, will discuss the differences between hibernation and anesthesia and why human hibernation is a fantasy for spaceflight at present. And one thing I want to say about this, I was overjoyed when I saw that your talk was on through Wonderfest, because usually in art, I'm sure you've seen this, you see some science magazine that says hibernation is possible, and you get some science writer who doesn't know what the heck he's talking about. And a matter of fact, I just saw this recently where one guy said, oh, yes, we're right on the edge of this. And there are these little chemicals. He didn't name what the chemicals were that would make human hibernation for spaceflight possible. So when I saw that there was somebody who actually knew what he was talking about, who was available, that's you, Art, I was overjoyed. And he's a professor, just to assure you that he actually knows what he's talking about. He's a professor of anesthesiology and perioperative care at the University of California, San Francisco, which is a pretty good medical school, almost as good as Stanford's. And the chief of anesthesia at the San Francisco, why are you laughing? We all know that's true. The chief of anesthesia, although my cousin actually considered teaching at UCSF before he got a better offer from the Portuguese government. He's the chief of anesthesia at the San Francisco VA Medical Center, a cardiac anesthesiologist, if you know about that stuff, very impressive, a biomedical engineer, clinical informaticist, and his research involves perioperative cardiac risk reduction. Art, I'm going to stop there because, you've made all these amazing discoveries, and I don't even understand what those things are.
Well, we'll talk a little bit about what those things.
Please do.
A little bit.
And so without any further ado, it is my great pleasure to introduce Dr. Art Wallace. Here you go, Art.
Thank you so much. Do I need the hand when I have the leveler?
It's behind your...
Okay, you can have that. So thank you so much for the very, very, very kind introduction. I am a cardiac anesthesiologist, and what that means is I do a lot of anesthesia for cardiac surgery. And I've worked on a number of different things, and I'd like to blame this talk on Tucker Hyatt.
Really?
Yeah, this is Tucker's fault. I was minding my own. I know it's his fault. I was minding my own business, and I was looking on Facebook, and I saw this article, and I thought that is the stupidest article I've ever seen. And so I typed that and said, "This is stupid." And Tucker said, "Could you give a talk about that?" So this is basically Tucker's fault. And what I would say is we're going to talk about human hibernation and why this is a fantasy. Everybody wants this fantasy, but it's really a fantasy. And if you don't get your question answered tonight, I'm at the VA hospital, art.wallace@va.gov. I'm glad to answer your question or whatever it is. And I'm going to talk about why this is a fantasy. Now, the first thing that you notice whenever people talk about hibernation is there's some recurring themes. Okay, there's white, plastic, lucite, and artificial intelligence. Okay, and this came from this article, which says astronauts will hibernate on long space flights, are not just in sci-fi. We could test this in 10 years. And I was like, no. They're like human subjects and feasible in a decade. Such experiments could pave the way for science fiction. Hibernate on the 1-year trip to Mars would prevent the boredom, save mission costs, save the hibernating crew don't have to eat or drink, use less oxygen, all kinds of great things about this. And they say research in animals suggests that hibernation could, reduce weight and do all kinds of things and not have damage. And the problem, then it says, of course, we need to fine tune everything so we can apply it to humans. And I was like, you're completely delusional that you think this is going to happen, mid 2030s. And when you think about this, the European Space Agency, look, long duration space flight to Mars will impose extreme stresses of physical and psychological nature on the crew. They think about this. They're thinking of the biology of hibernation to reduce metabolic stress. They can reduce how much oxygen and food and water, it could save money. And it's all going to be done through artificial intelligence and better monitoring. Okay, so it's going to solve that. And this sounds good. It sounds phenomenal, right? But what's wrong with this? And this has been in a lot of movies. We all remember Planet of the Apes, right? And they had the standard stuff for human spaceflight. They had white plastic, they had lucite, white clothing, no monitors, no anything, and they just magically slept there, right? Now, the other thing, right, but if you notice, there were some sequelae of this. This person had some neurocognitive dysfunction and died and rotted, so it doesn't always work out. So they were a little accurate that not every hibernating experience do you end up with a beard and nice clothing. So this went badly, okay? And these things have been done over and over again. Here's, 1950s thing, they used the sort of iron lung kind of concept, maybe some electricity to make this work. This woman didn't get white clothing. She had to be naked in the thing. But they were going to suspend the animation. And this, looks like the plumbing from a 1950s, ward for polio. And they thought, gee, we'll put this in the machine. We'll put her in the iron lung and she'll survive, okay? It's been done over and over again. Even Austin Powers was done. And no white clothing, but they froze him, right? And there's lots of different purposes for this. You could do long space flight, right? We could wait until some disease is cured in the future, okay? We could save a super spy for future use. We could store embryos and reanimate them when we need them. So there's a lot of different things that are good about this. And when you see this is the freezing embryos. This movie, they took a bunch of embryos, they put them in a thing, they froze them, and then they brought out a computer with some AI to reanimate them. And this is slightly more possible. You can freeze embryos. These are a little bit advanced to freeze. They look better in the movie, but you can freeze an embryo, and you can freeze an embryo for a very long time. And we'll talk about why that's more possible than freezing this level of embryo, okay? But, here's 2001. They had the AI, here's Hal did it. They had white plastic and lucite, and they slept. Now, Hal managed to kill a lot of them, but apart from that, it was fine. But they don't explain how to do this. And as a kid, I was like, this is the world's coolest thing. How would you do that, right? Now, even Woody Allen was frozen. This is from Sleeper. And what he did, he went in to have a gallbladder fixed, and they had some problems. And so they wrapped him up like a frozen food and froze him for a couple hundred years and woke up. And it was very realistic. When he woke up, he had neurocognitive dysfunction, which is pretty much, you're going to have problems with your brain when you wake up after being frozen for a long time. And society had changed, but they don't explain how to do it. There's no how-to manual. This has been used in many, many, many movies. And it basically, white chamber, lucite, artificial intelligence, and then you can fly to another planet for 250 years. They don't mention the details of how that's done in the movie. This one, this is the auto dock same thing. You toss them in here, you push a button, and all of the medical care is provided, and it works great. Sounds good. How? And I'm a kind of person, when I see science, I'm like, well, how did that work? This has been used in lots of things. It was used in Star Wars. You know, in Star Wars, it was a little different mentality. No white lucite. They used carbonite, and they put him in here, and they tested it. And, you know, when he woke up, he had neurocognitive dysfunction, had some visual problems, you know, had some motor control problems. So that was kind of realistic, but they don't tell you how to freeze someone in carbonite. This is so common that even Lego has a machine to do this. Here's the Lego freeze the guy in carbonite, and you put it in there and it pops out. I don't quite know how to do that. I'm wondering what it is. They don't explain it at all. And what the thing I would say makes me a little bit irritating is, like, here's torpor-inducing transfer habitat for Mars stasis. So they're so certain this is going to work that they're putting out contracts to build the vehicle. That's kind of pathetic. Yeah, I'm going to have the vehicle, and I'm going to say what the chairs should be shaped like, and I'm going to have, this person has some EEG stuff on them, but we'd like your money to design a capsule. We think it would be a good idea. We have no idea how to do it, and we'd like your money. Okay. And so that's kind of a little upsetting. But the basic themes in this: artificial intelligence, that's required, white clothing, lucite, and a giant cold slurpee machine that pours gooey stuff on the person, and some process that nobody explains. They got the white lucite, no monitors, no nothing. Okay. Now, let's talk about what is hibernation, because hibernation is a real thing. And hibernation is a state of minimal activity and metabolic depression undergone by some species. Okay, not everybody. And it can be seasonal. They get cold. They have low body temperature, slow breathing, low heart rate, low metabolic rate. And it's commonly in the winter, not always. And they do this to conserve food and to save energy, and they decrease metabolic rate. And it can last days, weeks, months, depending on the species and the animal condition and what's going on. And before entering hibernation, some animals become hyperphagic and they eat a whole bunch of food. Some don't do that. So they can have enough food for the dormant period. Bears eat a lot of stuff. Other animals don't really do that. And in many species, the food replaces them being becoming fat. Now, it's interesting. Some of the animals, like an Arctic ground squirrel, will hibernate. They'll drop their temperature to -2 degrees C. They'll appear dead, and then they'll be asleep for 9 months, basically. But once a month, they wake up, sleep for a day, and go back to sleep. So they spend a lot of effort re-energizing everything, turning everything back on, to sleep for a day, and then go back to sleep for another month. And we'll talk about why you might do that. I have a question? What's the question?
Oh, sorry. No. At the end. Oh,
At the end.
because that's what we do.
I want to follow the rules. Okay. So there's torpor, and this is a state of decreased physiologic activity in the animal marked by reduced body temperature, metabolic rate. And, hibernation is at low body temperature, lasting days to weeks. It can be, sometimes it's only 24 hours. My wife says she gets torpor every day. It's like 24 hours. I think she just likes the word. Rumination, there are different terms for this. If you have an animal that doesn't maintain their body temperature, they can hibernate more easily. And it depends on, is this a homeotherm or not a homeotherm? They often wake up to drink some water and then go back to sleep. Reptiles, eat more before they do this. And it can be 1 to 8 months, depending on the air temperature, size, health, and everything. And many of them don't really succeed because they're sort of slow. So young animals have a higher mortality rate with hibernation. Older animals some animals have a 50% mortality rate associated with hibernation. And it's, that it's cold and they go to sleep. Okay. Now, there's an interesting thing. If you take a rat and you put a rat in 100% nitrogen, The LD50, the lethal dose, 100% nitrogen in an adult rat is about 7 minutes, okay? If you take a fetal rat and you take the fetal rat and put it in 100% nitrogen, the LD50 is 60 minutes, okay? At 7 days of age, they're up at the adult rat phase. And so people have looked at this and thought about this, and turtles, the LD50 for 100% nitrogen is about 4 months. And when my kids were small, my wife got a tortoise named Luigi. And Luigi would come out and he lived in our kitchen in a kind of glass thing. And I came home and I was like, honey, where's Luigi? And she said, oh, he's underground, right? And I looked in there and I couldn't see Luigi and he was gone. And after about 3 or 4 months, I said, look, Luigi must be dead. I mean, I don't see Luigi. She says, he's fine, don't worry about it. So a month later, Luigi comes up, eats some salad, and goes back to sleep. Now, if I buried you for 4 months, first it'd be a crime scene, but you wouldn't do well, right? But, you know, Phil Bickler did an experiment where he took a turtle, put it in 100% nitrogen for 24 hours, took the serum from that turtle, gave it to a rat, and the LD50 was 60 minutes. So there's some thing that a turtle does that prevents hypoxic injury. Now, when you think about hypoxic injury, which is injury from not enough oxygen, there's sort of two things. There's the injury from taking away the oxygen, and then there's the injury when you give the oxygen back, and they make a bunch of superoxide radicals which destroy stuff. This may be some enzyme, some protein that affects the calcium channels and prevents calcium entry when you have reperfusion. We don't know what it is, but there are things that can make animals live longer. Now, when you think about chilling something, and we chill a lot of hearts down, okay? If I chill your heart to 30 degrees C, you live at 37 degrees C. If I chill you to 30, you'll probably fibrillate, okay? If you take a bear and the bear is hibernating, the bear only drops their temperature to 34. They're not like a ground squirrel that goes to -2. And the reason is that they're large, okay? If you have a large animal, they can have ventricular fibrillation. And so right out from the start, we can't take you to -2 degrees C because your heart will fibrillate, and then we'll have to figure out how to restart the thing. So there are different proteins in the heart of large animals. There are different things that don't tolerate it. And large animals can't really hibernate at these very low temperatures because of ventricular fibrillation. The next thing is that the myocardium of these animals is different. They have different proteins. And when you look at the myocytes of the animals, they have very different electrical activity in their heart. They can tolerate these low temperatures. And there's this thing called connexin 43, which allowed them to hibernate and not have ventricular fibrillation. So if I want to make you hibernate, I'm going to have to figure out how to give you connexin 43, okay? Now that's not completely absurd. I reviewed a study this month for our IACUC committee where they were taking a protein from an Arctic ground squirrel and giving it to a mouse to see if they could prevent strokes. So you can move these proteins around, but you may have to change your DNA to make you tolerant of just the cold, okay? Now, when I made this slide, I've spent months thinking about this slide. This is a really cool slide. I woke up this morning thinking about this slide at 5 a.m. and thought about it for about 5 hours. Some animals can be frozen, okay? And there are lots of insects that you can freeze. You can freeze some marine invertebrates, including barnacles, bivalve, and gastropods. You could take a wood frog to -14 degrees C, and they do fine. Turtles can be underwater for the whole winter, frozen. They come up. I'm a turtle still. Their blood has cryoprotectants that prevent forming ice crystals. Now, the other thing this one is really a cool thing, which really has a bunch of implications. Scientists found a frozen Budella rotifer that had been frozen in permafrost for 24,000 years. I'll show you a picture. And they warmed it up and it was alive.
Wow.
Now, what does that mean? What that means is that that organism, which, there it is, Bordello rotifer, the freezing didn't destroy the membranes. Okay, so the membranes were intact. Enzymes were still functional. Electrolytes, it didn't lose the electrolyte gradients across the cell. And this may be the most important thing, that, if you wake the cell up and the electrolyte gradients are shot, it's not going to work. So it maintained the electrolytes. It had enough glucose to restart. It had enough ATP to restart. And that being alive is really this persistence of membranes, electrolytes, enzymes, and energy stores. So if you can figure out how to maintain, not breaking the enzymes, not ruining the electrolytes, you can freeze things. And being dead is malfunction of all this stuff. And so when you look at the transition from not alive to alive, it may mean establishing intact membranes, enzymes, electrolyte gradients, ATP, glucose, and getting all those things to work in every cell in your body. This thing is kind of not that many cells. If I come to you and I say, hey, I'm going to try to make this work in every cell, it's going to be problematic because you've got 10 to the 13th cells or something like that. Now, mammals. Some mammals are obligate hibernators. Ground squirrels, rodents, mouse lemurs, European hedgehogs, a bunch of things. And the temperature drops and they have to go to sleep. Some of them can do what's called facultative hibernation, where they enter it only when cold stressed. Okay, they're not obligates. They can do it if they're cold stressed. Now, go to the next slide. When you think about mammals doing this, there are big ones and small ones, and big ones don't cool down as much. Small ones, you can chill down a lot. And then there are lemurs, and lemurs are they're kind of related to primates. And the lemurs hibernate at high temperatures. It gets too hot and they decide there's not enough food and they hibernate at high temperatures. So the only primate-like animal that hibernates is a fat-tailed lemur, and they do this at high temperatures, not cold temperatures. So that there are lots of different ways of doing this, and they use different words for whether it's a reptile, an arthropod, a bird. Birds don't seem to do this that I could find. And when prairie dogs, they're, the white-tailed one is an obligate and the black-tail is a facultative. So you can have some choices. The only primate that does this is the fat-tailed lemur, and they do it at high temperatures, not low temperatures. Bears, people debate whether bears really hibernate or not. They drop their temperature to like 34. They sleep for a long time. They give birth. They nurse their young. They recycle their urine. They recycle water. They're pretty sophisticated. If you wake them up, you can kill them. So that's not a good thing. But bears are kind of what you'd like us to do, but they're complicated, okay? So when you think about this, the bears are recycling the proteins in urine. They don't destroy their muscle. They stay hydrated, okay, because they're metabolizing fat. They don't lose bone mass. They don't have osteoporosis. They don't destroy their muscles. They don't fibrillate. And that's very sophisticated. If I took you and I lay you flat for a couple of days, you would lose muscle, your skin would necrose, you'd end up with kidney failure, you'd get a pulmonary embolus. You wouldn't tolerate this. Now, I don't think it's just the fur that makes them tolerate that. There's something fundamentally different that lets them lie still. If I just had you lie still for a couple of days, you'd have problems. Now, the other thing is that this is not that healthy for 2/3 of all juvenile animals hibernate the first time die, and 1/3 of adult animals die during hibernation. Some die because they run out of fat stores. Some of them get eaten while they're asleep. Bears do better. 1% of bears die, but you wake them up and they don't do so great. And humans don't hibernate because we were tropical animals. We're just not, we don't have the enzymes. We didn't really need to do it. We don't know how to do this, okay? Now, what causes you to hibernate? There's an HIT protein that turns on. They've isolated this in mammals and it seems to do stuff. They've sequenced a bunch of things and there are these special proteins that come out. There is a special opiate that releases called D-allo-2-D-lutenkephalin, and this is a delta opiate. Most of the opiates in your body are mu opiates. They're analgesics, and they release this opiate that puts them to sleep. The hibernating woodchuck makes this delta opiate. People have taken this delta opiate and given it to people to see what would happen. And people think, oh, it's kind of an analgesic. But if I gave you an opiate for a year to make you sleep, you would wake up and be addicted to the opiate. Right? If I give it to you for a week, you're going to be addicted to it. So they don't get addicted to this delta opiate for some reason. And it depresses respiration and makes them sleep. Okay. So let's talk about can we preserve like just part of you? Like we can't preserve your whole body. Let's take, say, your heart. Okay. Well, what do we do when we stop it? I chill your heart down to 2 degrees C. I get rid of all the contraction. We perfuse it. There are people that think you can add hydrogen sulfide to make this work better. We don't do that at present. But the problem is you get ischemic injury. Okay. That's the injury of not having the blood supply. When I reperfuse it, I get oxygen-free radicals, and that damages more stuff, okay? We did an experiment many years ago where we gave a drug called RSR13, which changed the P50 of hemoglobin so you got more oxygen. And it was really lethal to people. So the reperfusion is really important, and it's got to be controlled, and you have to deal carefully. Now, if I put your heart on ice, 2 hours is okay. 1 hour is better. If I take your heart off of ice after an hour, I can notice that the diastolic function, that's the relaxing part, isn't as good. It goes up by a factor of 6 in how stiff it is. But at 4 hours, that's kind of the limit. After 4 hours, you've got a really big problem. Lungs, maybe 4 hours. Liver, 12 to 18 hours. Pancreas, 8 hours. Kidney, 20 to 24 hours. That's not going to get you to Mars, right? That might get you, to the atmosphere, but it's days, not weeks. And this is really controlled, perfectly done, all these kind of things, and we can preserve an organ for really 2 hours. 4 hours is kind of pushing the envelope. Now, what is the injury? Well, there's 2 injuries. There's the ischemia and there's which causes hypoxia, but then there's the reperfusion injury when I make a bunch of superoxide radicals and injure the cells, and then the cells go, hey, I should just die, right? Because why not, right? So there's a thing called apoptosis where they just die, and you can make some drug to stop that, but we don't have any of these drugs, okay? And there's lots of ideas. How do we hibernate? Well, we add a cryoprotectant, we get some protein from the hypoxic turtle, we get hydrogen sulfide, we make these antifreeze molecules like in small fish, but this is not going to be developed in 10 years, okay? We've worked for 30 years to prevent heart attacks, and we've come up with 3 or 4 drugs. You're not going to change your DNA in the next 10 years. It's not going to happen, okay? Now, let's talk about anesthesia for a little bit. What is anesthesia? Well, we have the ether dome, and this was done in 1846, okay? That was a long time ago. And we don't even know how anesthesia works. So it's been 170 years or something, and I still don't know how it works. Now, the best idea, this is the Meyer-Overton hypothesis. This is the solubility of a chemical in olive oil. So you take olive oil, you see what the solubility of this drug is in olive oil, and over 10 orders of magnitude, it tells you the potency of the drug. That means you're probably a fathead, okay? And it's probably dissolving in the opiates, in the lipids in your brain and disturbing something. But that's our best idea. Like your head is a bowl of olive oil. That's it. That's the theory. Kind of pathetic, right? Right. So, and the other thing I would say is you're going to hibernate on the way to Mars. This is what an anesthetic looks like. You've got a person, and then you got another person checking on the person. So if you're going to go to Mars, you're going to have one guy sitting in a stool for the whole way while the other guy sleeps, right? And we do this for like a couple of hours. We don't do it for a long time. And it's complicated. It's all this stuff just to keep you from not moving. And we have to worry about all kinds of stuff, like is your heart beating and your breathing. And one of the really important things I teach our residents a lot is chronic breathing is really good for you. You should do it like every day, pretty much all day. Now, anesthesia requires one anesthetist per patient all the time. And we do a lot of stuff. We maintain the blood pressure, heart rate, respiration, temperature, urine production, O2, PCO2, hematocrit, SpO2, airway pressures, anesthetic depth, fluid administration. And we do this for like a couple of hours and you get a giant bill, okay? Mortality rate increases with anesthesia. So the duration, it goes up. The neurocognitive effects go up with the duration. The other thing that we don't talk about very much is that if I turn off your brain, your autonomic nervous system kind of stops working. And then the autonomic nervous system learns to do nothing. So if I keep you asleep in the ICU for a couple of days and I tell you how you stand up, you're like, oh, I can't stand up. You put someone in space flight for a week, they may not be able to walk around for a couple of weeks because the autonomic nervous system is like, I should go on vacation, right? There's neurocog dysfunction. Your brain is basically like one of these chips that refreshes itself over and over and over and over again. And if you're not refreshing the memories, that's bad. If I squish a nerve, it stops working. Pulmonary emboli. If I just have you sit still, your blood will clot and you'll get a clot that goes up to your lung. Pneumonia, your lung collapses, nausea, vomiting, bed sores. We can't, when you see someone in a hospital, we do a lot of stuff just to move them around so that they don't have all this injury, okay? Now, let's talk about, like a simple idea. We're gonna fly from here to Tokyo, and we're gonna feed you a movie, feed you food, have you go to the bathroom every couple of hours, and maybe watch a movie, okay? You get pulmonary emboli from this. Flights lasting more than 8 hours, you get, pulmonary embolus. So this is when blood stops sloshing around, it clots and goes up to your brain or your lung. And that's a bad thing. You can really die from a pulmonary emboli. Then the other thing is cardiopulmonary bypass. I do this all the time, but this is not good for you, okay? It takes 6 people to anesthetize one person. Okay, 2 surgeons, 2 anesthesiologists, 2 nurses, and a perfusionist, sometimes 2 perfusionists. And when you think about this bypass run, the LB50 for a bypass run is 240 minutes, okay? Lethal dose, 240 minutes. Cardioplegia, about 60 minutes. We deliver 800 bubbles per hour to your brain, okay? And 800 bubbles per hour, you have neurocognitive dysfunction, all kinds of stuff. The circ arrest time, if we turn off the pump to fix something, we might get 15 minutes, okay? And I'm chilling the person to 17 degrees C or something, and I get 15 minutes, okay? Not a flight to Mars, okay? And then you need an ICU to recover. So this is not gonna be good for you, okay? And people have tried freezing people. This is a Russian cardiac surgery thing. What you do is you take the person, you put them in a large trash can, you pour ice in it, some salt water, the temperature drops, they fibrillate, you operate very, very quickly, and then you wake them back up again. And there's surprisingly high morbidity. When you look at anesthesia, what are we doing? We're dealing with anxiety, okay? We're dealing with the autonomic function. This is the power, sewer, electricity, water, heat, all that stuff. Pain, the placebo effect, movement, consciousness, and memory. And we separate all of these things. Like, I can knock out anxiety and have you still be conscious. I can get rid of memory and you'll still be functional. I can get rid of your ability to do intentional things independent of things. I can make you paralyzed so you can't move and you'll remember everything. And we do it all individually, and there are drugs that hit each thing. And this is the placebo effect, and it's basically enkephalins released by your brain, and we can block it with drugs. Now, when you think about the autonomic nervous system, most people don't think about this very much, but this is cardiovascular control, respiratory control, GI, temperature, renal bladder, sexual function. And it's controlling all of your organs and keeping you from dying. It makes you breathe. It makes your blood pressure normal. It's basically the control system to do all the boring stuff in your body. It's power, lights, water, sewage, temperature control, oxygen delivery, metabolic waste. And this thing is really important. When I anesthetize you, your autonomic nervous system kind of poops out. And so I have to take over for all of these things to make sure you don't die, okay? The autonomic nervous system is so important that if you block it with a drug like thalidomide during pregnancy, organs don't even develop. You don't develop your limbs. This is a really important thing that makes everything work. It's kind of boring, but it's really important. There's a sympathetic, which allows you to speed up and do things. This comes from your brain and then goes to a part of your spinal cord from T1 to T12, and it controls speeding stuff up, okay? There's a parasympathetic that slows everything down. It comes from the brainstem and the pelvic, and it slows everything down, and it makes your gut work. And this is basically like a distributed computer system, where you have a nerve that comes from your brainstem, goes down, goes to a lot of little CPUs all the way around your body to control stuff. And every couple of centimeters in your gut, there's another little CPU that makes your gut do the stuff, okay? When we put you to sleep, all this stuff kind of stops working. Now, we talked about Michael Jackson. He contributed more to anesthesia than many other people. And Michael Jackson had a really dumb idea. And that is he went to a cardiologist. Now, why was that dumb? The cardiologist looks at you and says, hey, you have good exercise tolerance, you're going to do fine. Okay? And he says, this guy can dance for 2 hours, he's not going to have a heart attack. Cardiologists are very cardiocentric. They think about your heart. They don't think about the rest of you. And they forget the idea that chronic breathing is really good for you, okay? And so he had no monitors, he had no capnography, no pulse oximetry, no measure of blood pressure, and it killed the guy, okay? So just because your heart's doing okay doesn't mean that all of the other stuff doesn't have to work. And if I give you a drug which knocks out your autonomic nervous system, you're gonna die. Now, many non-professionals don't learn this quickly enough. When you look, there were about 100,000 deaths from fentanyl, okay? We use fentanyl every day in the operating room. Very, very effective drug, use it in almost every patient, works great. But I've got $100,000 worth of monitors checking you, and I know what I'm doing, okay? When people do this at home, a third are found dead with their first use. So it's really dangerous. The Russians did a really interesting experiment. They wanted to see what would happen if you anesthetize people with no anesthesiologist present. And when you do an experiment like this, you should do it in a large number of people on one day, because the Committee on Human Research will stop you. They anesthetized 800 people with fentanyl gas, and 15% died.
Oh.
Boom. 150 people. So if you give people, we have good numbers, this is 19%, it's a good solid number. They sprayed fentanyl gas into a theater to deal with some terrorists, but it's really bad for you. In 1950, the mortality rate for anesthesia was 1 in 1,500. The mortality for general anesthesia was 1 in 200. 1950, right? And now in 2010, we're at 1 in 200,000 to 1 in a million. So we're talking 1,000-fold increase in 60 years, okay? Now, that's not perfect. You know, in 2023, inpatient surgical mortality about 1%, outpatients 0.1%. And we have cut the mortality rate from this 1 in 200 to the 1 in 200,000 through monitoring. And this is really important. In 1988, we mandated that you have pulse oximetry in the operating room. That cut our mortality rate in half. In 1992, we mandated capnography. That cut the mortality rate another 50%. This is so effective that the insurance company called us up and said, we can reduce your malpractice by 2/3. Like when the insurance company notices it, you know that's a real monitor. Capnography is measuring the CO2 coming out of your lung. Okay, it says that you're breathing. Now, what do we monitor? We monitor everything. FiO2, blood pressure, heart rate, ECG, temperature, breath sounds, movement, pulse capnometry, inhaled agents, blood gases, airway pressures, all kinds of stuff. And to show you how important this is, I got a call last week, and one of my friends is trying to build a machine to figure out why Navy F-18 pilots are dying. And they just seem to die and fly off into the distance. And I said, well, are you measuring the FiO2 that they're breathing? What's that? And I'm like, well, we should have a discussion because you want to know what they're breathing. And if they run out of oxygen, there should be an alarm, and that should be in the flight manual. They didn't even know what that was. A little embarrassing. It's the fractional inspired oxygen content. Okay. Now, why do we monitor this stuff? We want to avoid hypoxia. We want to avoid hypotension. We want to avoid tachycardia. We want to avoid malignant hyperthermia. All of these things that are really bad. And much of it is hypoxia, like not enough oxygen. We don't want people to remember us. I want to be unmemorable. We don't want barotrauma, airway pressure. We don't want right heart failure, left heart failure, all these things. And we've made all these monitors so that we can tell what's going on. And I tell people, we monitor you up the wazoo. I'm not sure where the wazoo is, but we monitor it. Yeah. And the other thing I would say about anesthesia that people don't really get is that these drugs are lethal. Okay. When the pharmacy called me up and they're like, could you label the drugs that are high risk in your drawer? And I said, well, you're going to put a sticky label on every bottle. Can we just label the drawer? She's like, okay. I mean, like all of these things are bad. The other thing about these are drugs we use all the time. But nitrous oxide, which has been around, I don't know, 150 years or something, if you give this to people for more than 12 hours, you inhibit their methionine synthase and their bone marrow fails. You can't give this for that long. Opiates, there are lots of opiates. They're perfectly reasonable drugs, except they kill you. And you get addicted to them. Benzos, you get addicted to them. Barbiturates, addicted. This one's lethal. All of these things are bad for you, and we get away with it for a couple of hours. We don't give it to you for a year, right? Oh, everything. If you do it wrong, what we're doing is using this incredibly dangerous drug safely. That's the basic idea. Now, what do? We induce general anesthesia. We put a tube in the trachea so we can ventilate the person's breathing. We monitor everything we can think of monitoring. We maintain the blood pressure, temperature, ventilation, and we wake the person up, we send them home. Okay? That's what we do. And what we're trying to do is have nothing happen. Okay? In medicine, there's a thing, EU, pronounced U, means nothing changed. So we call it euboxia. Nothing, no box got out of whack, everything is normal. And, the other thing I would say is this is a study I did in 50,000 people, and we looked at what happened if people's blood pressure dropped. And 11% of people, their diastolic pressure went below 630, their systolic went below 60, and if that lasted more than 15 minutes, it affected 2-day, 30-day, and 1-year mortality. Now, it's important to notice this, that it doesn't just kill you today. If you survive today, I injured the person and it affects long-term effects. So whatever I do to you in the operating room, I have to not just have you survive today, I really have to get you to survive a year. And a lot of people don't tell you what happens at a year. This is what happens with high blood pressure, 16% of people, diastolic over 120, systolic over 200. same sort of thing. 15 minutes, you start getting into trouble. This is not as lethal as hypotension. This is only 1%. This is 13%. You really don't want people to have their blood pressure drop. The interesting one is your heart rate. This is, if you let the heart rate in a person on our facility go over 120 for 5 minutes, it affects 2-day, 30-day, and 1-year mortality. And we spent a lot of effort not having your heart rate ever go over 120, okay? Now, and you can look, these are people that the heart rate did not go over 120. These are people that the heart rate went over 120. And you can see they didn't do so great. They pooped out, okay? Now, what about ischemia? Like, if I let your heart get ischemic, this is a study we did, 200 people, if they had no in-hospital ischemia, they did way better than if they had myocardial ischemia. You want to prevent that, okay? Now, the other thing is you want to deal with fluids. And we spent a lot of time worrying about how much fluid you have and what's going on with the fluid. We did a study where we looked at 2 million people in the US and looked at how much fluid they got. And if they were in Boston, they got about 1 liter more fluid than if they got in California. And if you got too much fluid, it was bad. And if you got too little fluid, it was bad. Now, you ask, why would too much fluid be bad? That seems like I should drink more water. I should drink more water. Well, for the last 630 million years of human evolution or animal evolution, we have had the IV for like 100 years, okay? Your cells don't know how to deal with too much fluid. You break the little membranes, you do a lot of damage, so that too much is bad, too little is bad. You have to get the right amount, okay? The other thing we have to do is we have to balance what your cardiac output is and your venous return is. And we measure your cardiac output and we know what your venous return is, and we have to match this stuff and get it all to work. We sit there and we adjust the inotropic state, which is how hard your heart pumps. We adjust what happens to your blood volume and how well your veins adjust. And we get you to balance so you have optimal cardiac output and function. Okay? The other thing that we want to do is not destroy your brain, okay? And when you look at this is a brain slice, and these are neurons, and they're all a little connected, very delicate little thing. And every time I look at a picture like this, I think, well, what would happen if I froze that? And to try it out, go buy a salad and put the salad in your freezer for a day or two, get it out and see if you want to eat it. And you're going to go, no, okay? Cardiac surgery, the bubbles are bad for people. Those lead to delirium, which is confusion, about 50% of people. Autonomic dysfunction. The brain needs to be functioning so that it keeps working, and freezing the brain is not a great thing, okay? The other thing about this, which is very weird, is that hibernating animals actually wake up every month to sleep. So sleep is something important. The other thing about this cardiac surgery thing of 800 bubbles an hour, when you look at this, something like 95% of people get neurocognitive dysfunction from cardiac surgery. And you say, well, what is neurocognitive dysfunction? What? 95%.
Wow.
So you say, what is neurocognitive dysfunction? What that is we do you an IQ test, and then we give you cardiac surgery, and then we come back and we do another IQ test, and it's not as good, okay? And you say, well, what do you mean by that? Well, my father-in-law needed cardiac surgery, and he was a professor of history. He taught college history, and he gets his cardiac surgery. That's great, but he couldn't read the newspaper for 3 months. My father was a physicist at Berkeley. He would eat lunch with the physics department every week at Spenger's down on University Avenue. That's my father, yeah. Roger. And he comes to me and he says, there's this guy in my department who's a complete asshole. And he went to have cardiac surgery, and now he's really nice. Does heart disease make you a complete asshole? And I'm like, no, we changed his personality. We sent bubbles to his brain. He's a nicer person. And he goes, well, there's this other guy in my department. Can I send him for cardiac surgery? And I'm like, no, you can't do that. But it changes people's personality, okay? Now, we monitor everything. We monitor the EKG, we monitor arterial blood pressure. This is in the arteries. This is the pulmonary artery pressure. This is the central venous pressure. We measure how much CO2 is coming out. We measure the temperatures everywhere. We know what your oxygen is. We know what the gases are coming out of you. We monitor everything because what we're doing is we're trying to move blood from your heart to your blood vessels. And we balance the output impedance of your heart to the input impedance of your vasculature. And we balance the output impedance of your veins to your heart. So this thing keeps working over and over and over again. And we're constantly adjusting this stuff to have you not have a problem. Okay? Now, what could go wrong? Well, blood volume problems, systemic vascular resistance problems, diastolic function, systolic function, heart failure. And the other thing is you have about 30 seconds to fix it. And the reason you have 30 seconds is that if I shut off the coronary blood flow to your heart, 5 seconds later, it stops working. If I turn it back on again in 30 seconds, you just pop right back up and you're fine. If it goes longer than 30 seconds, there's stunning of the myocardium. If it goes more than 15 minutes, you have real problems. So you really have to fix this stuff very, very quickly. We have all kinds of monitors, and the monitors are critical. This is the pulse oximeter. What it's doing is shining light through your finger. That's a little thing they go in the, and what we do, we shine red light, infrared light through, and the deoxyhemoglobin and the oxyhemoglobin look different at the red and the infrared, and we can tell how much oxygen is in your blood. That's great. That one thing cut mortality in half.
Wow.
Okay. And we look at the AC signal over the DC for red and infrared, and you can put it on different things. Your nose, your ear, you must have a thin cross section. Okay. And then capnography, that's what that is. This is a little thing. It's an infrared spectrophotometer. We suck gases into this thing. It tells you how much CO2. When I first started anesthesia, we had a mass spectrometer to do this that our department built, and we would suck the gas in the mass spectrometer and tell you what the answer was. But this is basically shining light through the gas, and it tells you how much CO2 you have and what drugs are present in it, and we can tell that we have the right amount. The other thing that's really critical about the drugs we use, and it's very different from normal drugs. When you swallow a Tylenol, we don't know how much you should take. If you swallow an opiate, we don't know how much you should take. But when I give you sevoflurane, I know that you need 1.9% sevoflurane in your brain. And at that level, 50% of people will not move if I stab them with a knife. Okay? And if I take it up to 20% more, no one will move. Okay? That's really weird for drugs. The other thing that's weird is I have a computer that tells me what the concentration is in your brain. That's really helpful, okay? And we look at the IR spectrum of the drugs, and we can tell what's in your blood, okay? And we basically sample. There's a couple of different ways we can sample the gas coming out of you and tell you whether you're breathing or not. And we have little tubes that sample what comes out. And when you see this, here's the pipe that's going in for breathing. Here's the thing going in your stomach to drain the goo. This thing is measuring how much CO2 comes out. This is measuring the airway pressures. There's a temperature sensor. This isn't just a lucite box and some white clothing, okay? This is very different, okay? And the reason is that we've reduced mortality 50% with these things. It's very, very important. And when you see the difference, here's comes in saturation and capnography, and here's the number of deaths that came in. So monitoring really, really, really works, okay? Now, when you think about a hospital, in an operating room, if you stop breathing, you have about 12 minutes until you die, okay? On the ward, if you look at the computer records, people die over about 12 hours. And the nurses didn't notice, and they kind of go, kerplunk. The nurse always described it as, oh, he just suddenly died. Well, if you look at the computer, it was about 12 hours that they weren't paying attention. And you can improve this stuff with better monitoring. This is in an operating room. Here's the place where the person stopped breathing. This black stuff is the capnography. Right there, the breathing stopped. It took 10 minutes, and then the saturation dropped, and nobody noticed it, and it was bad, okay? You don't want to do, this is bad, okay? But you can go in an operating room for a full 10 minutes before anything looks bad, okay? Please advance. And we're looking at everything. This is the capnography. This is, we really, really see what's going on in an operating room because we don't want to see this, okay? This is asystole, you know, and we're doing this in a controlled way. You notice the guy's blood pressure is 70. That means he's on bypass, and we can turn him back on again, back to life, okay? But that requires monitoring, okay? And it's a bunch of plumbing. It goes in the guy's neck. We feed it into your heart. We're measuring the arterial pressure, the central venous, the PA pressure, the central venous pressure. It's not some trivial thing that looks nice. This is a monitor I designed. It's called an ECOM cardiac output monitor. What it's doing is it gets a impedance signal coming from on the endotracheal tube. It lets you see how much blood is being pumped out of your aorta. It also lets you measure the systemic vascular resistance and the blood volume, okay? And basically what we do, we want to know what's happening. We want to know how much blood is pumping, what's the resistance, what's the impedance, what are you doing? And we want to do it quickly. And this is a normal tube that we put into someone's trachea to breathe for them. This system just has some extra electrodes on it. We plug in this blue plug, and it gives you the cardiac output, the systemic vascular resistance, and the blood volume. Okay, and this goes in and looks right by your heart. Okay, and these are plastic electrodes. They're made out of the same plastic as the tube. We've doped them with silver, and we measure the electrical impedance in 3 dimensions coming from the inside of your chest. Okay, it measures cardiac output, stroke volume, and systemic vascular resistance. Now, who people remember Elizabeth Holmes? What was she? She had a turtleneck sweater and blonde hair. What was she selling?
Oh, her.
No. She was going to have a blood test where I take 1 drop of blood and I give you all these tests like in quickly, right? 1 drop of blood. Well, the thing that kind of bothered me about Elizabeth Holmes, apart from her being a freshman dropout from Stanford with no knowledge, was that we've had this device for like 30 years, okay? This thing, you know, little box, you take this little thing, it looks like a postage stamp, you put 1 drop of blood in it, you stick it in there, and you get the blood gas, hematocrit, glucose, calcium, sodium, electrolytes, ACT in 120 seconds. So not only was she a criminal, the people that gave her the $1 billion didn't know the thing already existed, and we use it all the time, okay? Yeah, right. It takes, you know, this is, you know, a normal lab takes about 60 minutes. This is 120 seconds, you know, and the point of 120 seconds is when I go to a code, I want to know what's going on right now, right? Because I've been to codes where they sent the lab to the lab and it took them 2 hours and it comes back and the crit's 3 or the glucose is 8 or something really not compatible with life. You want to get this quickly, okay? Now, the next thing I'm saying is this is what monitoring looks like now. It's a morass of cables. People don't like it. This is stuff that came from the 1960s in the space program. They wanted to know, is the astronaut alive or dead? You stick a bunch of pads on them. People hate them. They're tied down, okay? And what we said was, look, if you're in the hospital, we should at a minimum know if you're alive or dead, okay? It shouldn't be a Schrodinger cat kind of question, okay? And so what we're making is a new monitor that every patient in the hospital gets ambient sensors. And we just know if you're alive or dead. We put a sensor up on the roof, it looks at the patient, and it gives you vital signs. No wires, no hoses, no tubes. What we do is we have a camera array, which has an RGB camera, an infrared camera, a depth camera, and we can find the patient in the room. We can track their heart rate, just looking at their skin to seeing the Eulerian magnification of the signal. We can look through their clothes and see if they're moving to give you the respiratory rate. We can look in the middle of the forehead to get pulse oximetry. We can tell you pain. We could probably tell you blood pressure. And that's going to make it so that we don't have this mystery of people being found dead in bed. Yeah.
Wow.
So this is our sensor, looks at the patient. It finds the patient in the room, gives you the heart rate, respiratory rate, pulse oximetry, pain, probably blood pressure, and we'll just make the room smart. Okay, This is looking at me. I've got my nice blue shirt on. It's looking through my shirt. This is the infrared signal looking through my shirt, giving me my respiratory rate. This is me in the dark. And you can tell if people are breathing because chronic breathing is really important for it. This is looking across the room, looking at the urinary magnification, getting respiratory rate and heart rate to tell you that the heart's beating and make sure that people are not tachycardic. This is looking at me sitting in the room. It's looking at a little place right in the middle of my forehead, giving me the pulse oximeter, and we're checking it against other pulse oximetry. So we can do pulse oximetry as a reflection of the patient, not having to put some sensor on the finger. And then we can also, set this up in the room and monitor the stuff. This is looking to say, can we do pulse oximetry? And the answer is yes, we can do pulse oximetry just remotely. No wires, no tubes, no hoses, nothing on the patient. And so, what's the difference between hibernation and anesthesia? Hibernation is something animals can do. And it's lethal in 50% of the animals, right? Anesthesia without an anesthesiologist is lethal in about 20%, okay? And anesthetics are really short. They're, hours, they're not months, okay? And if you make them longer, you get pulmonary emboli, neuropathy, neurocog dysfunction, autonomic dysfunction, muscle loss, bone loss, bed sores, pneumonia, atelectasis, addiction to whatever drug you're using. And the thing I would say is that, we don't know how this stuff works after 177 years, okay? It's not going to be 10 years until we fix it, right? It's non-trivial to get a human to hibernate. We may need to change their proteins. We may need to make a new drug. It's not trivial, and you don't need to build the space vehicle before you figure out how this works. Human hibernation, it would be great. It'd be phenomenal. It would cut down on supplies, bone loss, oxygen consumption, but it's many, many years in the future, if at all, for primates. And people are always saying, hey, fusion, it'd be really cool too, right? Right? And it's non-polluting, unlimited energy, carbon neutral, but it's always 30 years in the future. And I think that's a similar time frame that for hibernation, it may be always 30 years in the future. So thank you so much. If there are any questions, I'd be glad to answer them. Thank you for inviting me. Yes, sir.
So is NASA funding millions? Oh, is NASA funding millions of dollars in grants to figure out how to hibernate people?
I have not applied for any of those. I know the people who would know how to do it, but I have not seen that. There's a lot of effort on organ preservation because being able to move an organ around is a big deal. That's a kind of simpler thing, and people have gotten better with organs. It used to be it was just 4 hours for a liver. Now it's 12 hours, but it's not. We haven't figured out how to do this, and I really think that you're going to have to solve 50 problems. The other thing about space flight that I didn't mention is that there are high energy cosmic rays, and those things are bad for your brain. And so having somebody lie still isn't the issue. You're going to make them into a less intelligent person by the time they get there. So I think it may be better to just go faster to get there rather than try to hibernate.
All right. One of the crazy things we do, is some of us anyway, is we go up to the White Mountains, and it's up at 12,500 feet at the High Altitude Research Center. And a couple of years ago, I don't know, maybe you were there, Bill, maybe
Yeah, our
not.
department does that a lot.
Oh, yeah. So there was a researcher who brought a whole bunch of hummingbirds with him and was studying the fugue state of hummingbirds. Of course, they got out and they were flying all over the inside of the building. But that's how he described it, as fugue state, because they were simulating cold weather by just bringing them to an oxygen poor environment. And I'm wondering if that is the same thing as you were referring to as torpor.
I'm not a hibernation expert. When I was looking up, do birds hibernate? There was a lot of things. Oh, birds don't hibernate. I bet if you were a hummingbird, hummingbirds have such high metabolic rates that if any bird is going to do it, they're probably the right one. Yeah, because they really have a very high metabolic rate.
So that's
so
a
that's-
factor in this is
Yeah, I mean, if the heart rates are quite high, the respiratory rates are enormous. They're really using energy. So if any bird has got to hibernate, it's gonna have to be a hummingbird. But I don't know. You're the veterinarian. Do hummingbirds hibernate?
But I'm a birder and I can answer that question. As I understand it, most ornithologists define what hummingbirds do. Anna's hummingbird is the only hummingbird that stays here in the Bay Area during the winter season. And they describe it as a torpor. They don't call it hibernation. And which raises the interesting question. What is the difference in your mind between a torpor and hibernation?
I think of torpor as you're sleepy and you don't do stuff for 12 or 24 hours. And hibernation is you let your body temperature drop and you really cool down and don't do anything for a long time. 24 hours to me isn't really hibernating, but I think of hibernating as a month or 6 months or something like that.
They seem to be sort of semi-aware of their environment and respond.
Well, then they're not, they're just kind of
They're-
chilling out.
Yeah, they're sort of chilling out, but it's clearly not hibernation.
But I'm sure if you made them hypoxic at 12,000 feet and cold, they're gonna like chill out more.
Yeah,
Yeah,
yeah.
yeah, something bad.
I always have 50 questions, so
You can have 50, it's fine with me.
I'm sorry, forgive me for interrupting your talk. First thing I want to say is, I think your talk is absolutely wonderful.
Thank you.
I found it fascinating and it makes me want to ask lots more questions and I learned a lot. And forgive me, but I'm wondering whether you'd be willing to give this talk to other astronomical societies.
I'm glad to give it to anybody who wants to hear about it. Because I mean, like literally,
Oh, okay.
let me say this morning, that slide of freezing the organism. I woke up this morning at 5 a.m. and I'm like, that really says something about what life is.
Yeah.
Like that really, I mean, I was sitting there like, what?
That was a tardigrade in the upper right of the picture, wasn't it? That weird thing?
Yeah, yeah. But I mean, it's like the fact that you can be frozen for 24,000 years and then come back means that's a hint of what is life. Like that's a really important
One
hint.
of our other frequent speakers is Dr. Chris McKay from NASA Ames. You probably know the name. And one of the things that Chris did is he would go out to the Kolyma Peninsula in Siberia, and they would take ice that had been geologically frozen for, I think, on the order of millions of years. And they would find virus spores in there, and they'd stick it in the microwave and put it, I guess, on a Petri dish, and the viruses would come alive.
You don't want to microwave because you'll denature them. But
Well,
viruses
he-
are not really alive. They're
Okay. Yeah.
they're sort of like code in a protective shell. Their instruction set. And this is the thing I was thinking about, is like, what is alive?
Yeah.
Like, what does that mean? Well, we know it reproduces and we know it has metabolic stuff. But one of the things I think is important in alive is the membrane potentials. And that we spend a lot of effort having the membrane potentials be reasonable and the electrolytes be reasonable.
You're talking electric potential across the membrane?
Electric potential across the membrane. And it's about 60 millivolts across your cell, and across the mitochondria, it's like 200 millivolts. And that's really, really important. If that fails, it's dead. And the thing I would say is, when you have a single cell organism, I can freeze it, I can maintain all the electrolytes inside there, and then I can unfreeze it and it doesn't break the membrane. Oh, I got it back. But if you have an organism with 10 to the 12 cells, how do I freeze it uniformly? How do I get all the membrane potentials to come back? How do I do that? It's more complicated. And that's why this is a fascinating talk, because I'm like, oh,
Yeah.
that really says something about what is life.
Well, I think that's one reason that I responded this way to the talk, because it opens up sort of vistas and different ways of thinking about things that you don't normally think about.
Yeah, I mean, I was like, oh, that's an interesting idea.
Now, I'm going to ask a variant of his question, which is, if we were to try to achieve hibernation in humans, what sort of directions do you think the research has to go to make that a possibility?
I think, there's a bunch of things you have to do. One is you're going to have to figure out like what to do about blood clotting. Because the reason your blood comes back from your legs is because you move your muscles. Okay, so you're gonna have to figure out blood clotting. You're gonna have to figure out, are you gonna breathe for the person or not? Like if you're gonna have the person breathe on their own, that's gonna be better because you're not gonna damage the endothelium in the lung and all that stuff. But you're gonna have them take a big breath every once in a while so they don't get atelectasis. If you think about the brain is basically reprogramming itself over and over, every once in a while. Well, even the stupid ground squirrel wakes up to reprogram its brain once a month. So you're going to have to think about what to do about the brain and how you're going to get it reprogrammed. You're going to have to pick out some drug that's not addictive. Now, when you think about addiction, if you take a rat and you give the rat morphine for a week, then you take the morphine away, you come back 3 months later, the rat is still addicted, and it's addicted permanently. So opiates change the histones and what the DNA is in part of your brain that makes you addicted permanently. So you're gonna have to get a delta opiate that doesn't cause addiction. And you're gonna have to figure out, how do I make sure the heart doesn't fibrillate? I mean, you've got 50 problems to fix. How do you not lose bone mass? How do you get your immune system to tolerate 0G? Because if you send somebody up to space, their immune system kind of poops out and they get infections that are weird. There's a lot of, and then what do you do about the high energy particles? There's a lot of stuff that's expensive and complicated. And that's why Sagan wasn't wrong when he said, hey, let's send a robot to Mars. That's it's like 1% as expensive and you don't kill anybody. And I have a solution for the Mars problem.
Which Mars problem?
How to go to Mars. I've solved it. You ever seen those bipedal robots like IBO or whatever it is? You send a bipedal robot to Mars and you put an American flag and the name like Bob. And he's got a tent and he sits in the tent. And when he stops working, we'll all go, oh, sorry, Bob died on Mars. Half of people on Earth wouldn't know that was a bipedal robot. They would think it was an astronaut. It's 1% as expensive. It would be really good. You're not going to kill anyone. And you don't have to have him hibernate. You can just turn off his battery for the year to get there. That is so much cheaper and so much safer. And it's not as much fun or cool, but it's much more probable than this.
Well, you're not getting that Elon Musk.
Oh, one of my residents worked for Elon Musk, and I said, hey, tell Elon about this. And then his car goes up with that robot in it. So he's thinking the same thing. Yeah.
This may be the answer to the Fermi paradox, which is, why aren't they here? Because it's too dangerous, it's too expensive for them to personally go. They would send out probes. That would be a much better way to go. And if you lose the probe,
you're like, okay, fine.
yeah.
Yeah.
But especially if you have long-lived creatures that, intelligent aliens that live for thousands of years, the loss of just one would be like a national tragedy. So they don't want to risk.
Well, I mean, just the radiation problem is a
Yeah.
big deal. There's a lot of, it's non-trivial to do this. And the other thing that's kind of interesting is if you say, well, hey, how many people voluntarily go live in Antarctica? Well, Antarctica is paradise compared to Mars. It's got air, it's got water,
It's got good cooking.
it's got, it's like a 5-hour trip to Argentina or whatever it is. I mean, it's paradise. And I don't see any of you going, hey, let's go to Antarctica to live.
Some of us would, but we're strange.
Yeah.
Does anybody else have any questions?
I do have one question. Are those capybaras or what are those?
No.
Those are tapirs.
Those are tapirs. My
Yes.
wife likes tapirs. And so I sent the tapirs on spaceflight. And that's Dolly. I did not draw that. Dolly drew that. I was like, get hibernating tapirs on the way to Mars. And that's what Dolly came up with.
And train them.
Yeah.
To do
Space flight. Because my wife likes tapirs.
Does anybody else have any questions? Art, thank you very much.
Oh,
That
thank
was
you for
one of
having
our
me.
best talks ever. You are funny. I regret I have to apologize. Our newsletter did not go out this month because our newsletter editor, I think, is hiking in the Dolomites in Italy or something like that. And is that where he is? He's somewhere.
He's
Yeah.
suffering.
He's suffering. Yes. So, or in New Jersey. Well, hopefully, thank you very much.
My pleasure.
Actually, you're probably, you're more mobile than I am. We did get some, and actually, I'm gonna encourage people to watch this on tape. This is a great talk. Thank you very, very much. I have to talk with your wife because I have met her somewhere before.